All right, well, welcome everyone out there in our virtual spaces, near and far. Thank you for joining us today. My name is Jennifer Malkowski. I'm an assistant professor of communication arts and sciences at California State University, Chico. And I have the privilege of moderating today's panel, which is entitled, Are Vaccines the Answer, or Just Another Question? This is the last event in our contemporary issue series of RSA Remote for the 2020 season. And so I thank you so much for being here. Before I turn the floor over to our panelists, I did want to just give a few thank yous to our co-sponsors of this event, UT Austin Department of Communication Studies, as well as Indiana University Department of English. We appreciate the support and efforts that our sponsors continue to provide for RSA. I'd also like to give a shout out and a warm-hearted thanks to the behind the scenes RSA Remote team that has worked all year to bring you programming. Specifically, I just want to thank Jerry Hauser, Casey Boyle, Krista Kennedy, Jeff Clegg, and Eric Detweiler by name, because they've worked weekly and usually daily to make sure that this whole RSA Remote endeavor got launched effectively and continues to run smoothly. We hope you've enjoyed the programming thus far, and we are excited to announce shortly our spring 2021 programming. But in terms of today's event, I want to encourage our audience to participate in a couple of ways if transcription services are something that you'd like. In the top left of your screen, you'll see that you can click on the live button there. That's Otter Transcription Service, and so that'll give you a live transcription service of our event today. I'd also like to encourage you to submit questions in the chat feature of our Zoom session today. We, as the panelists and the moderator, we intend to field your questions throughout the event, but also towards the end, we'll reserve some time. And so now on to today's event. Today's panel brings together scholars and practitioners to consider the intersections of rhetoric, vaccination, and COVID-19. Each distinguished participant brings with them experience and expertise that covers quite a wide range of vaccine-related issues, audiences, and contexts. I've asked each panelist to actually introduce themselves to help us all understand kind of this wide array of voices that convene here today. And so without further ado, I'd like to now ask each panelist to please introduce yourself and tell us a little about your experience with vaccination research, policy, advocacy, and outreach. And I've asked Heidi to go ahead and kick us off.
Thank you, Jen. And thank you so much to everyone here today for the invitation. This has been great to connect with some new and old faces for this project. This has been really exciting. So again, my name is Heidi Lawrence, an associate professor of English at George Mason University. I've spent the past 10 years researching vaccine controversy and vaccination acceptance across a wide range of populations. I am a medical rhetorician, so obviously, which is sort of like nice to be in an environment where I don't have to explain first what the humanities are and then what rhetoric is and then what medical rhetoric is as a part of that. So I'll skip that explanation. But as a medical rhetorician, I am really curious about people's lived experiences and how they use language to navigate controversial spaces in health, science, and medicine. And specifically with vaccination, I try to understand what vaccines really mean to people and all people. So doctors and public health workers and public health experts, as well as parents, patients, and people across the sort of sphere of vaccination. And the goal of the research is always to sort of move away from standard assumptions about that kind of emerge out of deficit and why people might be hesitant or question vaccination. My book, Vaccine Rhetorics, came out just earlier this year in February 2020, and it features interviews through textual analyses of physicians, public health, patients, and parents, and their views on vaccination, and considers the larger exigencies that keep vaccines controversial among the public, despite their kind of unilateral agreement among scientists that they are safe, effective, and the best way to respond to disease. My scholarly work has appeared in a wide range of spaces, including, I just have a new article out with John Gallagher today in the Journal of Medical Internet Research, Critical Public Health, and the Yale Journal of Biology and Medicine. So I do try to publish work on rhetoric in medical fields, but I've also been published in RHM and Journal of Medical Humanities. And my outreach and engagement work has included a wide range of activities, including an article earlier this year on vaccine acceptance and COVID, co-authored in Newsweek, co-authored with Bernice Hausman. Last year, I was in a performance of Eureka Day, which if you're unfamiliar with that, you should check that out. It is about vaccine controversy at a small school, and was in a panel public discussion afterwards. Have consulted and worked with the CDC as well as the Virginia Department of Health in the course of my work. So that's me.
Thank you so much, Heidi. I wondered if Tian would go next, please.
Thanks so much, Jennifer. Hello, everyone. My name is Tian Johnson. I'm an activist and the founder of the African Alliance. My history is in women's rights and reproductive justice and HIV. More recently, since 2013, I, with a group of other activists, HIV activists around the globe, established a group called the Vaccine Advocacy Resource Group. And this is a group of activists that work to ensure that vaccine research is accountable, transparent, and community-owned. Since the advent of COVID, we've had to pivot and make sure that we're on top of all COVID vaccine research issues. And so we do a range of programs around ensuring that the barriers between science and communities are broken, and that communities are able to have the level of scientific literacy to enable them to hold science and research to account. And just in the last 3 weeks, I have been appointed to the Ministerial Advisory Committee on COVID vaccines, and our task is to begin to develop and expedite the national COVID-19 vaccine rollout plan, beginning with 3 priority groups: those over 65, those with comorbidities, and healthcare workers and other essential workers. So a large part of our work is really focused on how, in this period, we can think through the communication of how prioritization happens, especially in communities who might really have a desire and a need to access a COVID-19 vaccine. Thanks, Jen.
Thank you so much, Tian. Lisa, I wondered if you'd go next, please.
Yeah, hi, everyone. So I'm very honored to be here. So thank you so much for inviting me. So when I think about my interaction with vaccines and vaccine research, it's a little bit more diffuse. I started out with this type of work in the pharmaceutical industry when I was working in regulatory documentation. I've worked in biomedical publication planning, and for several years I had a job where I basically traveled around, mostly in Europe, but also in Asia some, just working with different people on their publications and getting to interact with a lot of the folks that we're hearing from in the news right now. So that was very exciting work, but a little bit behind the scenes. And what I've been doing now that's a little bit more kind of intersecting with COVID, I'm on what's the International Society of Medical Publication Professionals. We've got a steering committee for good publication practice. We're introducing some information in there about public health emergencies. We're updating the ethics guidance, so I'm leading that. I've got a book coming out. It's actually coming out today. It's the 2nd edition of a volume on regulatory documentation from the Regulatory Affairs Professional Society. And I realize that this isn't super sexy sounding, but it's the largest regulatory affairs group in the world. And it trains a lot of people in terms of how to engage with these discourses. And we had to update quite a lot of the chapters to manage COVID. So if I think about that type of work, that's one type of work. Michael runs the Cohen Center at James Madison University. He and I wrote a couple of book chapters on COVID. One of them's for a book that's under contract with Routledge, and it's Global Communication Voices about COVID. So the authors come from all over the world. So there's people from Africa, Asia, Australia, North and South America, and Europe. And what I try to think about in the work that I'm doing, because it's a little bit diffuse and it's a little sort of bit haphazard because I've come to these spaces from different places, I'm trying to think about ways that my particular talents can kind of help the most people. It's like, what can I do? Where can I intervene? Where is that profitable? And then how does one manage the kinds of questions that Heidi's talking about when we're talking about different audiences and reaching out to people? So if I loop back to my industry experience, I used to spend a lot of time, what I called translating from English to English to English. So you'd have to be able to manage what's the register for the bench scientists who are sitting in Italy and who do this kind of all day and interact only with other molecular biologists. What's the register for people who need to interact with the public health authorities? What's the register that we can put in a newspaper? What's the register when we're talking to somebody? They're called payers in this system, but the people who actually have to generate funds and fund vaccination. So thank you again for having me.
Thank you so much, Lisa. And last but not least, Kirk, please.
Thank you, Jennifer, and thank you all for the chance to be part of this panel today. My name is Kirk St.Amant, and I teach health and medical communication and usability and design for Louisiana Tech University. I also have an adjunct faculty position in international health and medical communication with the University of Limerick in Ireland, and I direct Louisiana Tech University's newly formed Center for Health and Medical Communication. Most recently, we've joined the Louisiana Department of Health's Committee on COVID-19 Awareness and Promotion, in which we're working to develop different kinds of informational and instructional materials about vaccination to be distributed throughout the state. So I look forward to today's discussion. Thank you.
Thank you all so much. And I really appreciate you each giving us some detail about the various different angles that you study and participate in vaccination discourse, policies and practices. And though it wasn't a specific, contentious, interesting question that we were all tackling and answering, I think what we all witnessed was actually seeing the various ways that somebody like a rhetorical scholar can actually jump in and start joining conversations about vaccination with an interventionist spirit, or at the very least joining teams to sort of bring a humanities angle to the conversations at hand. And so right now I'm going to transition to a set of actually co-authored questions that the panelists have come up with and crafted that really get at the heart of some key issues and considerations that we think are really animating our current situation. And so we'll start off with a more general question about what panelists do you think that the role a rhetorical communication scholar can or should play when it comes to vaccine policy and practice? But specifically, how might we use the current COVID-19 situation to inform that ongoing work at the local, state, regional, national, and international levels? Would anybody like to jump in to begin? Lisa.
I guess I will. So, and it's just because I'm nervous and I don't like the silence. But one of the things that I think is really important when, again, I'm considering all the different places that I pop in and out of. Oh, and I'm just realizing I probably didn't say where I am from. So I'm an associate professor at Hofstra University in writing studies and rhetoric. But if I'm thinking about all the different spaces where our work intersects with other types of work, are we able to try to receive that work on its own terms and thereby be better heard? Because one of the barriers that I've seen when I'm presenting, say, at a scientific meeting and I'm trying to talk about the concepts that come up in rhetoric of health and medicine or writing studies or rhetorical studies, is that there's kind of a lot of translation needed to get things into a register that those folks can understand. But once you get it into that register, people are like, wow, that's a really great idea. Where do I get more of this rhetoric of health and medicine? But then when you give them the primary publications, there's a lot of barriers to their being able to take that information in. So that would be one thing.
Others.
Thanks, Jen. I mean, I think from our perspective, at the outset of the pandemic, we saw how important communication and language was in really conveying the urgency of how the pandemic landed in the country and what people needed to be aware of and have front of mind. And for the first time, we saw a group of people who were traditionally never really listened to or taken seriously or being given a public platform, really being centered in the national discourse, and these were scientists. And so you saw scientists become massively popular at community level, in terms of the way they communicated and how they communicated these very key principles. In South Africa, we went into a hard lockdown. So there were very strict curfews, total ban on the sale of alcohol, ban on the sale of cigarettes, and tobacco products, really, and really restricted opportunities for businesses to operate. And we really saw, for the first time, politicians taking a back seat and scientists taking the lead in terms of how they communicate. So one of the advantages, if you could call it that, that we've been experienced since the advent of COVID, was that coming from a history of, like ours, of science denialism, you actually saw science becoming really, really popular, and how communicating science in certain ways to different audiences really positioned communities in ways that they would take control of their own risk and understand their own perception of risk better. So that's how we experienced the initial phase, and of course made comparisons with the days of HIV, where we were wondering why, for example, people were not wearing masks or were hesitant to wear masks. And today we still have communities, you know, where people will say, we haven't seen anyone die of COVID. This is not our problem. It's a class issue. It's those who travel internationally. Whereas with HIV, the argument was a lot clearer. You know, we would see our mothers, our sisters dying in front of our eyes, and we knew there was treatment. Now with COVID, especially with asymptomatic COVID, it's a much more difficult risk to communicate to communities, to encourage them to protect themselves and stay alive.
John, are we allowed to ask follow-up questions instead of speak?
Absolutely.
Tian, could you tell us a little bit of, because that's such a stark contrast, at least in parts of the United States. I think we have some people who, like, our big person is Dr. Fauci, and we have people wearing socks with his face on it and things, but that's just like one segment. What were some of the strategies that you saw that were really effective at bringing everyone together under such stringent conditions?
I think it was really just the way that the scientists communicated. I mean, Tony Fauci and Deborah Birx before the pandemic in South Africa were well known really across the board. And then, of course, you saw how the politics evolved, and Deborah Birx then falling out of favor for a range of reasons that we might all be familiar with. But Tony Fauci really, so we actually characterize some of our top scientists, oh, that's our Tony Fauci. So I think the strategies they used were a range. You know, you had these very succinct, clearly worded opinion pieces in national media. You had community radio dramas happening. These are all traditional methods that we used with HIV to reach communities and to convey messages, and not only to communities, to universities, to our government stakeholders, to ports of entry, to border control, to all of the people who needed to really have an intimate understanding of why the lockdown was taking the shape it was. And so you had a really great balance, I think, because as much as you had really solid science and a government that believes in science and stands by science, you also had a group of communicators who were really smart in terms of communicating key concepts. So a sporadic bushfire analogy was really popular and used at the outset, where there were these images of a whole lot of small fires, and the scientists would walk the country through around, well, this is how we contain this one fire, and if we do that, well, it won't spread and join the other fire, you know, and really create a roll-on effect. So I think we had a really smart way of hitting all angles, from tabloid media to print daily media to daily slots on national news of scientists explaining to a news anchor who didn't have, you know, a science background, really breaking it down in really clear terms. So this is the science, and what does it mean? This is a very clear argument around why we're doing a total ban on alcohol, for example. So they would show a slide and show how workers in the emergency unit were actually relieved, and workers in the emergency unit shared that they had never been so relaxed. There was no work. But the day they allowed alcohol sales, just in one area, we had 49 drunk driving cases, we had death spike, stabbings, etc., etc. So I think they did a fair job at communicating, and it certainly stood out to us as activists and civil society, because something we hadn't seen from our traditionally anti-science government.
Tian, thank you so much. And it is getting me thinking about, so when we have novel disease outbreaks, we often rely on infrastructures and sense-making devices that we've used to navigate through and sometimes continue to navigate other disease outbreaks. And so I know the analogy between thinking through HIV and AIDS and the various ways that we responded to it or haven't on an international scale is kind of a ready-made metaphor or analogy that is used quite frequently to, I know you had just brought up the masks or something like that, the early days of such and such. I wondered if we could talk about maybe some concerns with using past infrastructure or different disease types to then sort of help make sense or bring the public on board and use that as a communication strategy. Do any of you have thoughts on that? I see Kirk nodding his head.
Well, forgive me if I may, but one of the things that we're seeing, at least in Louisiana right now, is there's this idea, we've created these infrastructures before for disseminating information about public health. So let's just go to the playbook and try it again, without realizing that, well, no, communities are individual, unique things. They're their own ecosystems of interaction that have their own norms and expectations. And if you begin to approach this as a marketing campaign, you're going to really lose a great deal of trust around it, particularly with individuals and groups that are suspect to begin with. So it's a matter in terms of, in a role as individuals who study communication, teaching these public health officials and the individuals in charge of managing these public health campaigns, you've got to go into communities. You've got to research the community by interacting with its members, and you've got to do so and communicate that in a way that makes them feel part of the process and part of the group generating the product or the message. And from there, it's a matter of testing that message with members of the community. So this idea that, again, treating it like an advertising campaign, it's the same old playbook, we're marketing this product, we're going to roll it out in the same way, simply won't work. It requires engagement, and it's engagement where we need to be listeners, not speakers, and students, not teachers, and collaborators, not sort of the purveyors of something. And so I think these are ways in which we can make meaningful contributions by even teaching ourselves to listen, learn, and to adapt, to work with others.
Kirk, do you think that rhetoricians have a skill set that helps them be particularly well poised to do that type of work that you just described?
I think yes, in terms of understanding the dynamics of research with other people communicating in the moment based upon community groups. Most of disciplines are familiar with the concept of a focus group or an interview or a user test, let's say. But those take on very different dynamics when you're in a healthcare situation where individuals need to discuss things that might be sensitive in other cases. And it's a matter of understanding the linguistic forms used to convey questions and to respond to answers. Those are, I think, valuable skills we can teach, but also it's a key opportunity for us to use those same skills ourselves to learn. What do we need to learn and understand and advance our own knowledge so that we can be better at our tasks and activities through this kind of collaborative effort?
Lisa, I see.
Yeah, sorry. So, Kirk, that was excellent. Thank you. But what I was going to say to kind of piggyback on this is the material conditions of this particular public health emergency are radically different than anything we've seen in an extremely long time, because the very places that are used to being in a position to afford aid to those who are being ravaged by some emergency are the places where the emergency is occurring. So the World Health Organization doesn't know the answer. The US CDC doesn't know the answer. The health authorities in Europe do not know the answer to these questions. And it really heightens the importance of the type of rhetorical and communication work that people in our kind of discipline can do, because much of what's going on is the fact that the rhetoric can't be anchored to anything because we don't know the answer. So you're needing to really manage a situation that's of material uncertainty.
Mm-hmm. Which makes our title for today's session quite on point, right? It just seems like rhetoricians are great at asking prior questions, but also navigating questions as they arise throughout, which is definitely a skill that, thank you for bringing that up as well, Lisa. Other comments?
Yeah, Lisa, that point particularly hit home for me because just this morning we were speaking about one of our prominent scientists, Professor Qureshi Abdul Karim, who actually sits on the National Coronavirus Task Team, she frequently reminds us that there's more that we don't know than that we do know. And she characterizes COVID-19 research as building a ship as it sails. And I think for me, that just really captured where we are. So even as activists, for different diseases, we're kind of used to very clear cut, you get guidance, you get prevention, risk, etc., etc. And here, it's almost a balance between flying in the dark, day by day, your message is changing. What does that do to advocates' integrity at community level? Because then communities think, oh, here goes the story changed again. And so, yeah, it's been nothing I think like we've ever seen. And I don't think we've gotten it right. And it'll be interesting to see how, as the vaccine starts rolling out in the first quarter of next year in South Africa, how all of that is communicated and how all of this feeds into vaccine hesitancy, for example.
Mm-hmm. Yeah, and I think on this point, certainly there is so much unknown, and I like that idea of building the ship as it's sailing. And yet there are features of this experience that have made things very clear and inarguable in ways that have been quite sobering, disheartening, but also probably motivating. And so here I'm thinking about the relationships between racial and health disparities in COVID-19 and how stark and clear they've become in the US, but also on a global scale. And so I wondered, how do you all see vaccine figuring in as part of maybe a just response to COVID-19, both within and outside the US borders? Or just speak about racial and health disparities as it relates to COVID-19 as well.
I mean, I think, Jen, some of our experience has been that in South Africa, we have a health system that is inherited from apartheid. And you still have a health system where the majority wealthy white people are able to afford high quality medical care, but the majority Black people still have to face the violence of the public health system. The public health system that has been fragile for years and failing constantly. And so it's about, even without COVID, we already know and we've seen the power of stigma and how stigma has stopped communities from accessing chronic medication, antiretrovirals for high blood pressure, etc., etc. And we've had huge defaulting and lack of adherence on very key chronic health areas in the country. And so it's really been interesting to see, and almost a warning of things to come, that we would almost have to start back at square one in getting communities into the clinic. Never mind COVID, just for basic public health care, because now the clinics have become so stigmatized by virtue of, oh, we're going to get COVID at these facilities. So it's going to be really interesting to see how we rebuild trust in a historically flawed and racist healthcare system, at least in South Africa.
I think one of the things that this crisis is forcing us to confront is the reality of these concerns, that they're not somehow imaginary. There's been I'm really encouraged to hear stories like Kirk's and Tian's, where the real concerns that people have are being treated as real, valid concerns that need to be addressed and worked with in real time. That's not necessarily a part of public health or medicine's history. There's a lot of history of sort of looking at people who have questions about medicine and science and saying that they're engaged in deluded thinking, that they can't understand science, that they can't properly reason, they have reasoning flaws. That was the sort of running theory for a very long time, and I think still very much dominates the way some people understand why people ever question vaccines or science and medicine. And if this crisis is allowing us to expose that science and medicine is not some sort of objective space that serves people equally, that actually is built on a history of objectifying and torturing and really treating some communities in some ways that are very, very horrible, and ignoring their pain. If it allows us to sort of come to terms with that and to say, well, if those communities then have very real concerns about a vaccine or a treatment or even a mask or a regulation, that's valid, and we need to actually address that. We can't just dismiss it. I think that, then at least there's some moving of the needle in terms of public health and medicine and public and popular acceptance of the fact that being hesitant or resistant isn't a sign of ignorance, but rather a very natural and sometimes logical response to how one has been treated in the health system.
I mean, I know, forgive me, I mentioned that I just come from a meeting about this very topic before we had our meeting today, but some of the things that came up are the problematic assumption that you know what the cause of a concern is. There is a predisposed attitude in a specific group, but we know what the cause of that is, so we're ready to mitigate it without actually interacting with the group to ask, where does this concern come from? And so the desire to determine, well, actually meeting with the community to ask these questions, and they're difficult, but it's what is the cause of the concern, because the solution lies in knowing what that is. Then the second is realizing you're not in a position to dictate. And I mean that, I hate how this sounds, but in a beneficent way, where this is what is good for you. You're not in that position. There are members of that community who hold the authority there, who are the ones individuals will listen to. Have you bothered to learn who they are? Have you bothered to ask them what the best way of conveying what the community is? But at the same time, you're asking these community leaders to jeopardize their reputation and trust on your behalf. You better be ready to support them, to provide them with what they need, to inform them, and to make them active participants, to get that degree of buy-in. And then we come to the final part, which is sustainability, which seems to be at the crux of a lot of the trust issues that we're seeing today. We'll come in for this one incident, we'll deal with this one health issue, and then suddenly the interest is gone, the attention is gone, the focus is gone, the desire to maintain care is gone. It can't be that way. How do you establish frameworks? And I mean, infrastructures, everything from effective transportation systems to effective healthcare systems to even effective communication systems that make the sustainability of the quality of care possible from this event forward. So you know that the trust maintains itself over time, and you can build new precedents based upon real models, sustainable things moving forward. That seems to be the thing that we're focusing on right now in Louisiana, and hopefully we can achieve that model for sustainability moving forward.
Yeah, I might add that there's other things that go on sort of behind the scenes that influence kind of communities and community building and access to things like healthcare that get erased when we think about the medical community as the community that has control over this. So in the United States, because people's healthcare is often connected to their jobs, this kind of rise of a gig economy and also the proliferation of places like Walmart. I mean, Walmart is the major employer in many states in the United States, and they don't offer healthcare to the vast majority of their workers. So even something like, where is my livelihood connected to? What kind of access do I have to these sorts of things? Do I have the time and energy to get someplace? It's very easy to sort of lose sight of those type of very pragmatic details when we're thinking about things on a policy level.
You know, Kirk's point got me thinking about how, as much as we've learned lessons from HIV, we're also repeating a lot of the same mistakes. Um, Speaking about meeting communities and individuals at their point of need, it's only now in the last 5 years, really, that we've seen, at least in South Africa, the increased interest and focus on human-centered approaches, in the context of HIV. And so that just made me think around how, as much as we know, we're still actively not paying attention to the lessons that, diseases like HIV have taught us and shown us. So that's been interesting. And also the issue of intersectionality has really stood out. For example, since 2001 until today, there's been 48 women that we know of who were forcibly sterilized. And the attention that story had gotten was in large part because of the focus that COVID had placed on our public health sector. In any other time, there might not be as much traction in the media as we had, but because the news cycles have been so almost drenched in constant health news, COVID updates, death numbers, recovery numbers, when the story of the 48 women who had been forcibly sterilized and told that was because they had HIV and later found out they did not, some of these women only found out that they were forcibly sterilized because they tried to have another child and could not, and then found out that this was done without their knowledge. So we only found out that because of that increased focus. So that was really interesting to see how the increased attention on COVID really forced people to look into the health system. And then communities who had never had access to water since democracy, so over 20 years now, for the first time had access to water, and they could wash their hands because there was this pressure on government to meet its messaging of hand washing in the absence of water. And so they were forced to then rapidly provide water. So people are in some cases characterizing COVID as a blessing in disguise because for the first time they now have water as a direct result of the advent of COVID. So it's been interesting to see how our traditional alliances and issues that were separate have now really become so very, very closely linked, whether that's employment or access to sanitation or access to jobs.
Thank you all so much. This is, yeah, just getting me thinking about, and I'm sure our audience as well, just thinking about a lot of different things and how complicated this really is. Because Kirk, in listening to you, I'm thinking about how long a lot of that work will take to establish that trust, to then be able to make use of that trust, to mobilize quickly in times of need. And that is, you know, the question becomes, what corners do we cut? I hate to put it that way, but right when we need to be quick because this thing is upon us, right? And so, in what ways are you playing a short game and sacrificing the long game by doing so? But vice versa, to Tian's point, it also feels like we're making short-term decisions that might really have positive long-term impacts that we wouldn't have made in the short term because they weren't put on priority lists or they weren't intersectional. Like you had said, we didn't think about certain different realms working together, to Lisa's point as well, right? Workplace rights and health and well-being, and how that actually impacts our ability to manage and respond to a public health crisis has become very apparent within the US. And so I do want to shift a little bit in thinking about the various ways, because we often do use policy as a way to sort of instigate and mobilize bodies, and then also start to put money and resources towards particular pieces of the public health puzzle. Some of them have lasting infrastructural impact that we can make use, because Tian, to your point, I hope that that clean water continues, right? Because then we can move on to the next public health challenge, and that won't be a hurdle in the immediate if another disease, if and when another disease outbreak occurs. But in terms of this panel, I mean, this week has seen a lot of news. The US CDC advisory panel met and set a priority list for who would receive the COVID-19 vaccines in the US. And on Monday, we're expecting the UK to start rolling out their first vaccinations with a very similar priority list. And so I wondered if y'all could speak to, well, from the position of researchers and rhetorical researchers at that, what can we say about policy, logistics, and equity with regard to vaccination distribution? So the process of vaccine distribution, what does a rhetorician have to offer, or what does a communication specialist have to offer to that process, or commentary on that process and the outcomes?
Can I offer a thought first? Because I have a kind of a bridging thought from our last discussion, which is that, you know, and I think one of the topics of the day is like, what's the role of rhetoric here? And it strikes me as we're talking about all of these different communities and how, like, this is a rhetorical problem at a very basic level. We need rhetoric here because all we've been talking about basically is persuasion. And that's because this is a pandemic we're not going to be able to mandate our way out of. We are going to primarily be vaccinating adults first, and we don't have good mechanisms for mandating adult vaccination. Kids are really easy to ensure and achieve herd immunity through. That's why we vaccinate them. I mean, they're also at risk of disease, but it's a really convenient system. We can cut off their access to public school if they don't vaccinate, in the United States anyway. But adults, it does not work the same way. And so I think that that perhaps like the stories that Kirk is telling and that Tian is telling about trying to understand publics and audiences, trying to reach out, meet them where they are, those recommendations felt radical like 12 months ago. The idea of engaging a community that was resistant, why would you engage a bunch of idiots who don't understand science? why should I engage with them? We're just going to mandate this and they're going to do what we say, whether they like it or not. That was 100% where the arc of our laws and our policies were going. But when you're talking about something where the intervention is adults, we need rhetoric and we need persuasion and we need all of rhetoric in all of its forms, not just persuasiveness, but that understanding of deep context and situation. So I think that relates to the policies that are going to roll out as well in terms of who gets this when and in what order, and who accepts it and who is going to be eager for it, and how are we going to get up to a large enough threshold of immunity to start going back to normal life and at least like stop having so many people dying. We're going to have to persuade people to do this. The mandate avenue is not as available to us with this pandemic in the United States. So, persuasion and rhetoric are going to be key.
Can I build off of Heidi's point very quick? You raise an excellent point about the need for persuasion and communication. It all comes down to rhetorical concepts. And I wonder if the key concepts involved are those of transparency and accountability, because it seems as though the great problems that are occurring around the communication aspects are information is either not being shared, it's not being shared effectively, it's not being shared in forms that are portable from one group to another, and there are continual issues with transparency that threaten the credibility of things, but also conveying the accountability factor. Admitting to the fact that we're rolling out a new vaccine, there will be problems. They always happen. We need to be transparent about that. And when they do happen, come up with a structure for responding and holding individuals, if needed, accountable for things and being very direct and open about those factors. But a lot of the issues we've discussed around trust come down to, are we being transparent about what is happening? And if there is something that happens, are we holding individuals accountable for things and being transparent about what's being done? And so I'm wondering if those areas might be the ones in which we can make very important contributions. How do you create those messages, both preemptive and responsive, to prepare for these issues so that people feel that they're making informed decisions, and that if something does go amiss based on their informed decision, that a correct path of action will be taken in response? And maybe that's a general question I'm asking the group.
So one of the things that you guys are talking about this, I'm like, yes, like we need people here who are being transparent, who are kind of meeting these communities, but it's also about taking the information and packaging that in a way that it makes some kind of sense. So there's this discussion, it's like, is this vaccine fully tested? I mean, these vaccines have been tested in tens of thousands of people. If we think about how many people you would test a vaccine in before mass vaccinating infants, these studies, these individual studies are orders of magnitude larger than that. And like that information isn't really conveyed. It's not like, well, how does this compare to vaccine development in other areas? It's kind of siloed in these ways that I think are not helpful. And again, people with training in rhetoric and communication are really, I think, ideally suited to, it's like, oh, well, if we take all of this and we read across it, we've got these reading skills, then we can maybe situate things in ways that help people understand, okay, so compared to this, this is what the COVID vaccine is like. So you got all these vaccines, so how tested was this compared to the ones that you already thought were okay? And kind of moving forward from there.
And I think, Lisa, one of the things that we've seen is even before the vaccine arrives, there's been no transparency. There's been no accountability. All of the 4 COVID-19 vaccine trials in South Africa have not released their access agreements. So communities who are supporting research through their tax money don't know what agreements have been made between their government and Big Pharma. They don't know if they're going to be prioritized. So even before the vaccine has landed, the unwillingness of pharma and government to be open around access is already putting us on a back foot in terms of helping communities or supporting communities to trust the process, because we're starting with shadows and smoke and mirrors from the very outset, and that's always a bad thing. And I guess one more point I just want to share is that I feel there's an overwhelming hunger for humility in science. And that's just not there. In the vast majority of cases, scientists don't feel that they need to go and engage with the community. Their job is the science, and their job is to get the next, research award or global prize or cover of a magazine or whatever, and advance their careers. But getting a science to come to community level and engage meaningfully and openly with communities is really a rarity. When one of the large trials was paused, for example, we reached out to the leadership of that trial and said, could you just speak in simple, clear English and tell communities why has this trial been paused? And it was just staggering to me, the almost gymnastics that they had to do. Just, you almost just want to go crazy. It's like, just say the word, just say it, and just, just speak. But you end up with the statement on a research institute letterhead that might as well have been written in Arabic or some ancient script, because it doesn't mean anything. And more frustratingly, it doesn't give us as activists who have the ear and the trust of the community the tools we need to explain why was this trial paused and what does this mean for us. So just two thoughts, but a particular one on the need for humility in research.
Yeah. Does anybody have anything else to say? Because this is more anecdotal. So I was working in Novartis Vaccines in Boston, and I'd been there for a very short time. And I got a phone call from the head of one of the big research teams. I was like, Lisa, come to this conference room, bring all your stuff. I need you for the rest of the day. And I'm like, whoa. So I go into this room. There's a journalist who's clearly been in tears. There's a marketing professional. There's the lead bench scientist and the lead clinician out of scientific affairs. And they've got a grid, and they're trying to do messaging for different groups. And they're like, okay, how do you say this? And the lead scientist is like, blah, 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 gobbledygook. And the journalist is like, simple language, slightly incorrect. And it's awful. I'm like, okay, well, what about this? So we literally spent the next 2 days in that room. Again, the translating from English to English to English. You need that person in the middle. So these guys, and I liked them a lot. I liked working with them. I worked with them a lot. I liked the journalist. It was great. But they literally don't have language other than what they talk to their buddies about. And it's very, very difficult to kind of figure out what's the register that it's still correct enough, but that it's actually accessible to other people. And I think that like Rhetoric Society to me represents a group of people who have those skills.
And I'm wondering, Lisa, if we've done enough to demonstrate the benefits of making the time and the effort of developing that language. Do scientists get the value of, because in their minds really, and we've been told this, it's, oh, don't dumb down the message. And we're like, well, that is so problematic. Communities have a right to information, especially around research that is happening on their bodies, in their homes, in their communities. And so it keeps on coming back to that arrogance of research. And if they don't have the language, do they self-identify as having a problem? Do they admit that me not having this language is a problem for the science? Because as we always say, all these billions in research are going to come to nothing if the communities aren't going to access the product, or if we're sitting with COVID vaccines expiring because people have bought into the narrative that Bill Gates is putting a microchip into vaccines to track them for some reason.
Well, he does that because he likes microchips, clearly. And plus we saw it on a science fiction television show. The one answer that I have to that is, I gave a talk at Rhetoric Society, I guess it was 2018, and I talked about how scientists view their work and the language that they're using as disposable. So what you're working on, particularly when you're at the vanguard of the known and the unknown, like that all could go away next week because you could be just totally wrong about it. So this idea that you need to have a message that's actually concrete for use in like real human life, for scientists, it's like you need to kind of amass a lot of evidence before you have anything that's worth investing that in. So I was on a phone call with a very well-known rhetorician of health and medicine, Celeste Condit, and we were talking about this. And I'm like, most of the bench scientists I've worked with, they work 15, 20 years. They never get anything that needs to be written up and sent to a government agency because none of the research they do works. So if we think about what it's like in those communities where it's like, oh yeah, we're doing stuff and we're continuing to do stuff, but they're like 80% sure that it won't go anyplace. I think it creates like that's part of the tension. And that's again why we need groups like the NCA, or which is the National Communication Association, or Rhetoric Society, with people who concern themselves with that language.
Well, if I may, then how much of a role do journalists play in this in terms of acting as the conduit between the scientists and the general public, making sure they understand what they're reporting on in an age where faster, first to market, driven by the headline is driving a lot of the information around this particular topic. Sort of back to transparency and accountability, the journalists have a huge role to play in this. Do we need to be doing more to help them engage in those practices where they can convey information effectively? What can we do to help them as fellow individuals who work in the communication dynamic?
Yeah.
And what we're doing in the next few weeks and over the holiday period is we've identified a select group of social media influencers. And so we're working with those social media influencers with the backing of the Medical Research Council to begin these Twitter discussions and Facebook discussions around people's real concerns. Because very often, because we're so on edge about the problematic history and context of which research comes, we don't address the elephant in the room. So we want to start asking, as Africans, what is making us hesitant around this science? And surfacing our concerns and our issues and dealing with them, as much as we can. So journalists, absolutely, we have great relationships with a lot of them who do really excellent work. There's a group here called Bekisisa that just does the most amazing work in terms of communicating these complicated concepts to the general public. But we're seeing increasing traction with social media and getting popular culture figures backed by scientists and activists to then begin these discussions on social media.
I just have a vision of like Kylie Jenner, George Bush, and, and Bill Clinton all lined up together getting vaccines. Maybe this is the way to do it instead of just our former presidents, adding a Kardashian into the mix.
Oh gosh. We do have a comment in our chat area. It's from a former reporter who notes that rhetoricians definitely need to do more to make the science understandable. And so I'd like to just expand a little bit more on what your thoughts are for the role or the entry point for rhetoricians. And so Lisa, you've described a situation where you're welcomed in as, I don't want to reduce it down to a translator, but you are helping different audiences speak to one another in order to reach a combined or joint end goal. There also, Tian, you just gave us really an exciting and interesting different mechanism or outlet way of reaching different various publics and thinking through who should deliver messages. Are there other roles that you all are currently playing as rhetoricians to join conversations, to do and help make the science more understandable?
Well, I think I would say that one thing with that translate from English to English, my example there, I was co-authoring a paper with the two kind of scientist people, and I also worked with the other folks. So it's like building credibility with people on their own terms. And to go back to Tian's point and Kirk's point, and also what Heidi's talking about, is when scientists are kind of like working in a particular register, it's very difficult to break in there and to demonstrate that you're an actor who's worthy of being listened to because you've done enough homework to master enough science. And this is kind of something, again, for everybody on this call, there's a lot of people whose names I'm recognizing who I know teach. It's like, even at the undergraduate level, it's like kids are kind of getting kicked out of STEM curricula because they don't automatically pick up the language. Like that's something that we can be doing, every single one of us each day, is kind of helping those students get better access into those fields just through being able to speak the language correctly, or I'll put quotes around that.
And in that vein, I think there's so much that just needs to be done at the level of the discourse that we are exchanging in with our students, administrators, people within our universities, our family and friends, to to not come at this. I mean, things are so amplified and tense and raw right now in American political discourse that it's really hard to sort of encourage a middle road. But you can do the things that I think Kirk and Tian and Lisa are talking about here in your day-to-day life, of listening to people when they have concerns, accepting them as valid and real, and trying to understand their view from within it, rather than sort of saying like, I just won't engage, or you're crazy, there's no way that's ever going to happen, or other things like that. I think working in a person and modeling that and showing how to do that in day-to-day life makes a really big difference to helping to at least start with your own sphere to calm it down a little bit.
All right, we are just about out of time here. And so I wanted to take the last couple minutes to thank our panelists so much for joining together to discuss the intersections of rhetoric, vaccination, and COVID-19. As our title so aptly communicates, we are left with more questions than answers, as should be the case. And it is a challenge to study something that feels like you're at once completely enveloped by it and also chasing it. And yet that's the work that lies ahead of us. I think each of you are doing just really remarkable work out in different fields with different communities. And hopefully everyone joining us today really got a feel for the various ways that rhetoricians or communication specialists can join groups and initiatives to help understand and respond to disease outbreak. And so with that, thank you so much. We will be recording this, or it has been recorded. And so our behind the scenes staff at RSA Remote will be putting this up on our RSA YouTube channel shortly. And I also just want to give one last shout out and thank you to our co-sponsors, UT Austin Department of Communication Studies and Indiana University Department of English. Thank you all so much. And I look forward to working with you all in the future and hearing about your work as well.